Thank you. Let's see here. What's going on, Lakeisha? Let's see. I want to get it. Wonder if I can. There's really no in between there, huh? Hey, I'm in Arizona too. I'll give it a few more minutes and see if we get a couple more people on. I'll record it anyway. People are messaging me right now, asking me about payer guidelines. I'll go into that a little bit too. Give it like a few more minutes. Do you have any questions, Lakeisha, maybe that you like answered while I'm doing this? Maybe I'll hit. DNP, simple practice. Yeah, I love simple practice. It makes my life so easy just because it's got so many different things it can do with especially the billing. The billing makes it really easy. So I love the billing capability of simple practice. That's probably my favorite part. It's just because it's so easy to get claims through, get claims paid, track it. I mean, I probably have a 99% clean claim rate through simple practice, and it's just so easy to use. Okay. Charts and billing. Yeah. Well, shouldn't be doing charts. You should have them AI do your charts. Let's see. People are asking. So people want to know how people are asking me questions about my AI. Let's see.
AI. I wanted more from EHR. Reason I left it. Yeah, you know what? I like stuff more rudimentary because when stuff gets too complicated, it really starts to screw systems up. So like, especially for my note taker that I use, I like it really rudimentary. So I don't like something that's so confusing that people can't use it. Like this is my note taker right here, and it's got the back end. I got coded with. Oh, it doesn't show my drop downs there. I don't know why. Um, so weird. You can see them change there, but I got like discharge summaries. I have CPT audit check, so you can check your notes. You just paste them in there. I got basically everything: TMS mapping notes, Bravado. I have Locus, ASAM, and I use AI, making sure I have everything before signing. Yep, that's true. You want to make sure you have everything in there. That is true. But yeah, I mean, it's very basic. I don't like my stuff to get too complicated. It starts to screw things up. And it's funny when I go to like a hospital and I'm working in the administration's like, well, what do you like to use for like your note templates? And I'm like, just give me a blank box. That's all I want. All I want is a blank box. I do my note with AI. I copy it. I paste it in the box. I don't click anything. I hate clicking buttons, and it saves me so much time because I don't have to click anything. And that's, you know, not clicking things is like one of the best things ever, honestly. We'll pull that back up. Actually, we are here. Let's see here. All right, we have 24 people on. Let's get going. So most of you guys, I wouldn't say most of you guys, some people don't know anything about billing, and that's okay. So there's something we call medical complexity. Medical complexity is how we determine what bill code we're going to use partially, or we have time that can also determine what bill code we're going to use. So when we're talking about billing visits, there's a couple different levels of billing codes we use. We use 2, 3, 4, and 5. So in psych, we use 99212, 99213, 99214, 99215. Can you guys type into the chat what code you use most of? Go ahead and throw it into the chat there. If you use mostly a 99214, 99213, throw it into the chat so we can talk about it. I want to see what you guys are using. So go ahead and throw that into the chat. Throw into the chat what code you're using. For me, it's mostly, there we go, 99215. There we go. There we go. Good, good, good. Very good. Excellent. That's what we should be using. We should be using 90792. Good question. So some payers, let me share some stuff I should not be sharing here real quick. Here, I'll show you. Some payers, their 90792s pay like crap. So Aetna and Blue Cross, Cigna, I don't use a 90792. I use a 99205 because those codes pay like crap with those payers. Here, let me pull up my Aetna fee schedule and I'll show you what I mean real quick. And we can't, this is supposed to be proprietary information, right? So let's see here. I'll pull it up for you. Here we go. Let's pull open that new fee schedule. Also ask for raises, by the way. Here we go. All right, here is a fee schedule. Let me blow it up. So this is my actual fee schedule. Now, well, this is the Aetna fee schedule. So I get 100 and something percent of fee schedule. So when we look at the fee schedule here, right, let's look at a 90792. Let's see what that pays here. So here's a 90792. See, for an NP, it's $136.17. That's for an NP, right? That is for an eval. If we go down to a 99205, right? Go away. There we go. It's 180, right? So that's a big difference. Good job negotiating your raises. I do the same thing. I negotiate raises every single year. Well, I try to. They don't say yes every year. But yeah, so I don't always use a 90792. Therapy add-ons. Yep, always use a therapy add-on. See, a lot of people though, and that's what I wanted to talk about, they don't use the therapy add-on correctly and they get audited and they take money back. And they do it all the time. I talk to NPs all the time that give money back on their psychotherapy portion of the note. So there's things you need to know when billing psychotherapy. And what I use is I use the payer guidelines. So that in Optum is the strictest. That's why I use Optum payer guidelines. Those are here. These are Optum's payer guidelines, right? We have the psychotherapy services, and then we have Optum's E&M services here, right? So it shows you an example right here. I'll zoom in here and I'll scroll over so you can see it, hopefully. Here we go, right? So if you look at how it's set up, they have to be separate and identifiable, right? It says here, cannot be used in, you can't use them in conjunction. So they have to be separate, right? We have to have them separated. So we should have our E&M note separated. So if you look at my note down here, my sample note, let's back out a little bit. You see how I have my evaluation and management portion down here, and then it ends, and then my psychotherapy portion starts. So it's got to be separate, right? And the payer guidelines all state the same thing, right? No, you do not have to document start and end time. You don't. So you only have to document total time, right? So if you look here, it's documentation for the psychotherapy. So let's go ahead and zoom into let's go to the guidelines. I always go to the payer guidelines. So if you look here, it says based on face-to-face time, and then we document total time, a separate diagnosis. And if you look below the time-based add-on codes, you see that blue there. If you look down below where that bold is, document the time, right? Total time. So you don't actually have to put a time frame. No, you don't have to do a start and end time. I'm 100% sure. I've sent in notes. It's total time, right? So you don't have to do a start and end, right? You only have to do a start and end if you're doing a time-based therapy code. And remember, when we're doing therapy codes, and this is different than E&M coding, right? This is specific to therapy. You only have to hit 50% of the time limit. So when we're talking about a psychotherapy add-on, what's 51% or greater than of the 30 minutes, right? It's going to be 16 minutes, right? 50%, you get 51%. So that's specific to therapy notes, not specific to E&M visits. So, you know, if you try to document an E&M visit based on that, you're not going to hit it. So the most important thing you understand about documenting the psychotherapy services is it's got to be separate, right? It's got to be separate and identifiable, right? So separate E&M visit, right? Medical decision making, we'll go over that. Then your therapy note. You can't have it just jammed into your note. That doesn't work. Now, can you get some of the medical decision making information from your therapy note? You absolutely can. Absolutely. So let's get into medical complexity. So 99214, it's very easy to hit every time. The APA has pretty clear guidelines on how to hit it. And I think most of us should probably hit it every single time. So let's look at these. And this is from the APA, right? So when we talk about medical decision making, the easiest way to hit that 99214 is going to be through column 1 and column 3 here, right? So column 3 here, we got column 3 and we got column 1, right? So when we look at what the APA, it talks about what the diagnoses are, right? So when you look at one or more chronic stable illnesses or a self-limiting, it's like they don't really give you an example. So it's like, is depression a self-limiting disease? Is anxiety self-limiting? It's like you can't find anything in the CPT books. They don't tell you anything on the payer guidelines. So those kind of things you actually have to go to the Psychiatric Association and look. What is considered a self-limiting? What is considered a stable chronic, right? And the APA states that anything that you're adjusting medications for, they haven't 100% completed the treatment plan on, that is considered a chronic illness with a progression, side effect, or exacerbation, because they haven't reached their treatment plan goal. So if you're still titrating meds, you're still changing doses, then that is a chronic illness with an exacerbation because they have not hit their treatment plan goal. That's easy, right? So again, if you're adjusting medications on a patient because they haven't 100% hit their treatment plan goal, then you hit it based on that one or more chronic illness with exacerbation, right? So that's really easy. The other one is 2 or more stable chronic illnesses. So this is if they have, and it says right here, right? They have schizophrenia and alcohol use disorder. Right? So we can always say like, depression or anxiety, that also works. Depression and anxiety work, right? But yeah, the most important thing to understand is it's considered an exacerbation, progression, or side effect if we're still treating it, right? So it doesn't matter if we're changing meds on a patient, then it's obviously they haven't hit their treatment plan goal, or we wouldn't be changing meds. So I think that's always confusing to figure out when you're looking at these columns. It's like, oh, anxiety, it may sound self-limiting, right? It does. And even if you look up here in the low, right, one stable chronic illness, depression, right? So if they have depression, recurrent or in remission, right, that's considered a stable chronic, which a lot of people don't understand. Yeah, exactly. A lot of people don't understand. So if I have someone that comes in with depression and I'm going up on their Zoloft dose, their sertraline dose, do I hit what complexity am I hitting here? Am I hitting a low? Am I hitting a straightforward, low, moderate, or high? Does anybody know the answer to that? Someone's checking in with depression and I'm upping their Zoloft. Type it in the chat if you know. Someone checks in with depression. They're coming to see me. They have depression and I'm upping their Zoloft. What level visit is it? Is it low, moderate, or high? So we don't know if it's a 99214 yet, right? We're just looking at this first column. We're going to get there. So it's considered a moderate, right? So it hits here, right? So it does hit that moderate. And then the next thing we're going to look at is, I'm going to look at that next column if I can get there, right? I think I can. Let's back out. You trying to do this here? Let's see. Look at that other column here. Oops, don't want to do that. See if we can crop that out now. There we go. That's better. All right. So then we're going to look at that next column, which is considered the risk for complication and comorbidity. Okay. So risk for complication and comorbidity, if we look at the different risk levels, right? If we're not doing any prescription management, it's considered low risk, right? Moderate risk, that's going to be in that 99214 category. Prescription drug management, right? Most of the time, we're always doing that. We're essentially always doing prescription drug management, right? Every time we see a patient, if we refill a med, management of psychiatric medications. So if we're managing psychiatric medications, someone that has depression or anxiety, or if someone comes in with depression and we're increasing the medication, that's automatically going to hit a moderate visit, right? Because we're managing prescription. Even if you're not refilling meds and you're just going over medications, that's still prescription drug management. Here's another one that people don't look at all the time, that diagnoses or treatments limited by social determinant of health. So there's a lot of them. Trauma, right? And social determinant of health is a Z code. So everyone can write that down, or you can look it up. A Z code, and you don't have to put it in your bill. You just put it in your note, right? So a Z code can be history of trauma, drug use, living in an institution, right? When I go to a treatment center to see patients, they're living in an institution, that automatically brings it to a 992, it automatically brings it to a moderate risk, even without prescribing any medications. So when we go back here, if I have a patient that has depression or anxiety, that's going to be 2 stable chronic illnesses, and I am refilling their Zoloft, that's going to hit a 99214. So you almost know what code you're going to hit before you even see the patient, right? Because we already pretty much know what we're doing with the patient, right? We know that they're coming in for whatever it is, a Zoloft refill, whatever the case may be. Now, this is where a lot of people screw up. It's the documentation of the psychotherapy part, okay? So, and a lot of people don't understand too that it doesn't have to be 30 minutes. It could be 16 minutes, right? As long as it hits 50% of the therapy time. So 50% of that code in a 90833 is 30 minutes with the patient. So above 50%, they call it 16 minutes. All right. So the therapy so some things got to be in the record, right? So the start and stop times or total time, right? Or total time, right? So if we have a time-based code, what is 90833? Is 90833 a time-based code? What is it? Time-based, right? Time-based, total time, right? Time-based. We only have to have the total time. Exactly. So you don't have to have a start and end time on there, right? Total time of session for time-based codes, time-based code, right? You don't have to have started at 4 and ended at 4:16, right? You could have the patient scheduled from 4 to 4:20 and write in your note, 16 minutes of this visit was spent doing psychotherapy, right? That's fine. But there's things that got to be in your note too, right? Obviously, this stuff is going to be in there anyway, right? Their name should be in there. Obviously, your credentials are already going to be on there. We already talked about the note. And then the important one is progress, response to treatment, and then the type of intervention used, right? So when we look down at my note, let's go down here. So here's my E&M portion first, right? So here's my evaluation and management portion. Manage my medications, right? Safety assessment. And then I even state why it meets that bill code. I don't know why I want to try to get this looking better here. I don't know if that's clear enough. Maybe it is. Kind of looks a little duty. But anyway, see how the psychotherapy section is separate? So I keep it totally separate. So my psychotherapy, and then it says CBT therapy, that's the type, right? They want the type of therapy. They want how long, right? So type of therapy, how long. I hit those 2 elements per Optum. So I am doing CBT therapy, discussing strategies for coping with life transitions and managing anxiety, right? And then we also have the treatment plan for psychotherapy, right? And my AI tool will do this for you if you just, and most programs are set up to give you somewhat of a semblance of what to do, but you got to make sure you have the treatment plan too. You can't just throw in, talked about sleep hygiene, right? It's got to be like, track this, track that, discuss it the next visit. So that kind of stuff has to be in there, right? And what I'll do is let me see if I can give you like an example here. Let's share this tab. We'll go through it real quick. So let's see here. We'll go right there, and I'll just paste like a fake conversation here. We'll take a look real quick, and then you guys can help me figure out what code it is based on what we do here. So I like this because usually what I'll do is I'll go into my EMR and I'll paste in the patient's diagnoses, I'll paste in the med list, and then I'll dictate, or I'll click the start record button while I'm in with my patient. And of course I let them know, and it'll record our conversation. And there's some guiding questions that I use, but let's go ahead and generate this note. And this is just based on a 2-minute conversation. Here, let's see. And see, I asked it to give me a follow-up note without therapy, but let's go through it and figure out what kind of visit it is first. And we'll run an audit check on it too. Somebody said a stable MDD and GAD with one medication. Okay. What is MDD considered? It's considered a stable chronic, right? What is GAD considered? Stable chronic. One medication, prescription drug management, 99214, right? It meets the elements. We have prescription drug management and 2 stable chronic illnesses, right? So here is my note here. I have 2 diagnoses, right? 2 diagnoses. So that is a level 4, right? And then I have an increase of Lexapro. Lexapro increased to 10 milligrams. So that's medication management. And right here, it even says why it meets that level. It says the moderate complexity is supported by the presence of multiple comorbidities, MDD and GAD, and medication management with a dose adjustment, right? So let's run it through as with psychotherapy and kind of see what it does here. But yeah, a lot of people get the psychotherapy portion wrong. Either they don't know how much time it's supposed to be, or they don't know what's supposed to be in the note. And I use this code pretty much every visit. It's what I use almost every visit. So I've had to send in notes. You know, I've had P&I audits, which means like, hey, you're billing a lot of this stuff. We want to see your notes. The interpretation of tests, no, because it's got to be external. Okay, you can't interpret your own stuff from your own EHR. So it's very clear that the interpretation of screening tools has got to be external. They cannot be internal screening tools. So you cannot use that to justify a 99215 visit. If you're reviewing notes from another provider, that counts. You could build a 96127 code for the screening tool. It's like $5, but you cannot do that. And I'll show you why in a minute. So again, we have our E&M note here, right? Evaluation and management. We have our 2 problems, right? That meets a moderate complexity. And then we have to figure out the risk level, right? We have medication adjustment that meets that risk level. And then we have our psychotherapy, right? And our psychotherapy, we have how long, right? It's a time-based code. We have our treatment plan, what they will do, right? And that's all based on my little conversation I pasted in there. It says patient will reduce anxiety related to the upcoming test by utilizing structured study sessions and flashcards to increase perceived control over preparation. Objective, patient will document feelings and after using the flashcards and report changes in anxiety level in the next session in 4 weeks. And then what I do is before my visit with them, I just peek back at what I talked about. And if I don't have a psychotherapy topic, this is pretty good at coming up with one. It'll take one literally from our conversation and give me a topic. We'll talk about it and then so on and so forth. So it's actually really good at creating psychotherapy topics as well. So, and if you guys feel comfortable throwing down in the chat, how many of you bill your own 99214s and 90833s and see the reimbursements for them? Anybody in there? Gotta be somebody. Good for commercial. Well, they're also good. They're not that bad for Medicaid either. So let's go ahead and let's look real quick. Let's go ahead and pull up. We'll do the access, which is the Arizona Medicaid fee schedule. So if you guys can all see here. So this is for, anyone can use it. This is Medicaid fees. So let's look at the reimbursement for a Medicaid, 99214. So let's look at that, 9214. So let's all check that out. So we're a non-facility, right? So, and we are a provider type 19 in Arizona, which is a nurse practitioner. So let's call it 86 bucks. So we have $86 for the 99214 portion. And then let's add on our 90833 portion. Let's see what it's going to be here. So we have $86 and we have, let's call it 69 bucks. Okay. Let's do 86 plus 69. That's 155. And that's even for Medicaid. That's horrible. That's actually not bad at all. 155 bucks. It's not as good as Aetna or Cigna and I just got a new, I don't know if you guys can see this, but thank you for the reimbursement increase request, right? And then they gave it to me. So I send those in all the time. I always get rate increases, and then they sent me a new, they send you a new fee schedule with all your new rates on there, which is crazy. So I see I get a lot of psychiatrists on TikTok. I don't know if it's hate or really, but they really question my bill rates and how much I get paid per visit. But the problem is a lot of these people don't know that you have to ask for rate increases. They're not going to just give them to you. So I was looking at a guy's contract, and he was getting paid like $58, and this is a psychiatrist. This is an MD, right? And he was asking me about reimbursements, and I was like, yeah, my Aetna is like 114 bucks, and my Cigna for that combo bill code is $204, and my I do have a template here. I'll share it with you. And my Blue Cross Blue Shield is like $214, for that combo code. So I look at those, and then I would see that they've never asked for a rate increase, and I'm like, well, no wonder. You have to ask for those. Here, let's see if I can show you what I got here. So I'll copy, let's see, I'll give you a little rate increase. Template here, but yeah, you have to ask for a rate increase. Let's see if I can share this with you guys. I don't know if you guys can see that. Yeah, you probably can. But this worked. So, and I can share this with some of you guys too. But essentially, I'm asking for a reimbursement. I would like to formally request a 15% increase in my reimbursement rate. Yada, yada, yada. And then it states why I feel like I deserve that. And I just basically use AI, AI, provider relations. And, most of the time I end up getting a pretty good answer. Let's see. I get them quite often. Show you I just got a Cigna one, just got an Aetna one. Yeah, and they're not going to just give them to you guys either. They don't just give you rate increases. Oh, that's an old one. That's when I was arguing about rates again. So I ask for them quite often. Oh, my face is huge there. We'll go back to that. Credentialing company I recommend. No, I do it all myself. So, and it's easy. You use the CAQH, right? So here, I'll log into mine right now. CAQH, right? Let's see if it shares it. Let's see. So it is, right? So here's my CAQH profile. And this is where they pull everything for credentialing. So you have the CAQH portal here, right? And most of your employers have already created you one. And you go into your practice locations and you add your practice locations. See, here's all my practice locations. There's so many of them damn locations for me, right? Because I'm licensed in all these states: Colorado, Virginia, New Mexico, Arizona, Vermont, right? A lot of telehealth on there. And then you have your professional IDs, right? You have your specialties. So this is all you need. And then you give the disclosure here for the insurance companies to reach out to. Let's see if I can find it for you guys. It'll ask you. Let's see. So see this? So these are all the people that have access to see my CAQH, and then they can credential me, right? So these are all the plans that I'm in network with, right? So I have like Vermont Medicaid, Aetna, Magellan, Blue Cross, Health Choice. Good luck getting that one. Multi-plan, Mercy Care, so these are all the plans that I personally have a contract with. So credentialing is so you got to have your CAQH set up first. So you have to have this set up, CAQH set up, and then credentialing is so easy. You just like, let's pretend we're doing Aetna. I'll do it with you. This is exactly how you do it. And I take people through this crap all the time. It's so easy to join a network or to get credentialed. So I'm on the Aetna website right here, and it's just request for participation. I wonder if I can change the screen size for you guys to, let's see. Oh, you can't. Maybe that's better, a little better. Gotcha. So I'm interested in applying for Aetna. I want to do behavioral health. I'm joining an individual provider that is not currently participating, right? Here's what you need, really easy. I need a tax ID number. I need my NPI. Use your individual for the first one. Don't use your group because the group contracts are different. A W-9 and your CAQH. Every single one's going to be the same for that CAQH. You're going to need that for all of them. And then continue, really easy. You fill out this information and that's it. You get an email back in like 3 weeks. Welcome to the network, right? You'll get an email that looks something like, here, I'll show you. And I fill these out for people all the time where I help them anyway. Watch. You'll get an email that says, welcome. So you'll get something that looks like this. Welcome, right? Welcome to the network. So you'll get an email basically welcoming you to the network. Let's see if I can. No, that doesn't make it any better. But anyway, yeah, you get an email. They'll give you a provider ID, and those sort of things. So yeah, credentialing it's easy. Yeah, people that charge $3,000 a contract, and I mean it's market demand. If people are willing to pay it, whatever, that's fine. But credentialing is not like a very involved process. It's actually quite easy. But anyway, getting back to the 99214-90833s, the reimbursements, they're right around $200. And that's for almost every payer. Someone said they're in Maryland. Let's see if we can find a Maryland fee schedule together. I can almost find anything. I'm like a woman on a computer digging up dirt. Let's see if we can find it. Let's go to Maryland Medicaid fee schedule. Let's see if we can find that. Let's see here. Let's change this. Let's see if we can find a Maryland Medicaid fee schedule. I bet we can. I'm trying to make this like so you guys can at least see it a little bit. There we go. So let's see here. Is this going to find us a fee schedule? Maybe. Here we go. Fee schedule, behavioral health, fee schedule. Boom, that was easy. Let's look here. Outpatient fee schedule. Look how easy this is to find, right? It's not that bad. Oops. So I just click fee schedule and here it is. Individual practitioner fee schedule, right? These are the new rates. So let's look. Here we go. Boom. Here are the rates right here. Let's zoom in on it. Let's see. Here's a psych eval for a Maryland provider. Dang, 168, not horrible. That's not bad. 168 ain't bad. So let's look at a 90833. So that is 55, right? So 90833 is $55 for an MP and it's 77 for an MD. And then let's go down. Let's find a 99214. Here it is, 99214. Oh, you actually get paid more if you get a prescription with it. It's a different modifier on there in Maryland. It's the same amount of money. It doesn't matter. So it looks like 99 bucks for an APRN. So we have $99 plus 99 plus 55. That's 156. What was Arizona? Like what did we say? 155? It's like $1. Right? It's $1 difference. Right? So see how easy it is to find the fee schedules for different. It's easy for insurance, commercial insurance. They usually have the same fee schedule, but everyone's percent of the fee schedule is different, right? Some NPs I know take 75% of the fee schedule, right? Let's go to my Blue Cross. I'll take you there. Let's see. And then some people get a whole lot more. Like some of mine, I'm like at 105. I get 105% of fee schedule. Oops. Let's do it. Yeah, here we go. Let's log in. Provider. Let's do that. Okay. So this is what my portal looks like. And then we have our practice management. And then I have all the people that work for me on here. See, holy cow. That's a lot of people I have linked to me. But let's go down. Let's go down to me. Here, where am I at? Westerman, right there. Let's look at my fee schedule. Here's my fee schedule. Right? So let's type in some CPTs here and let's see what my fee schedule looks like with my CPTs. So let's do the ones I use most of. I do 99214 mostly. I do 90833. I use G code, so G2086. That's going to be opioid first month. And then I use a G2087. That's an opioid second month. And I use a lot of G2088s, which you can only use with Blue Cross and Aetna. Remember that. You cannot use them with the other payers. That's why, Aetna and Blue Cross, when you're doing opioid codes, they are really, really high paying codes. So let's look here. So let me get my head out of the way here for you guys. Let's see if I can move it. Let's look here. No, don't want to do that. All right. Well, that'll have to be good enough. So let's see here. So for my psychotherapy portion, it's $87. So let's go to calculator here. Let's pull that out. So I have $87, and then my 99214 for Blue Cross is $125. That's a good one, huh? $125. That's a healthy code there, right? So let's look here. See, I have my 99214, $124. So what's that total? What's that equal? $211, right, for a follow-up. Okay. And then here's my opioid code, right? That's first month. And if you look up my Note Genie formats the note how you need it for a G2087. But if you're doing Suboxone visit for Blue Cross and Aetna, $554 month 1, $512 month 2. So if you have 10 Suboxone patients and you see them once a month, right? That's $5,500 right there. And I probably have 30. Addiction medicine is mostly what I do. So I, go to these hospitals, I'll detox them, and then I'll send them to me outpatient as well. So those are G codes. A lot of people don't know about G codes. I love G codes. Most people don't know what they are, what they mean, and they're very good paying codes. Then let's look at a 90792. Let's look at that real quick with my fee schedule. Let's go ahead and punch that one in there. 90792. Let's pull that up. So we have a diagnostic eval. So 277. So see with this, it makes sense to bill a 90792, right? So I get paid 277.41. That's my BCBS contracted rate. That's my contract, right? So 277 is what I get paid for an eval by Blue Cross Blue Shield. And what would it be if I did a 99205? Let's look. Let's see if I did a 99205 instead. Let's look what it would be. And I do this with all the fee schedules, and I set up my billing system. So if I do an eval, it'll say like Blue Cross eval, and then it'll say like Aetna, Cigna, United eval. So I know what bill code to use that's going to yield me the most money, right? So let's see here. So for 99205, it's going to yield 214, right? So for this payer, 214 is less than 277. I'm going to go with the 90792, right? But as we just talked about with Aetna that I was showing you, right? Aetna is less, right? So we'd use that other bill code. And then Blue Cross is great too, because you can actually do Vivitrol codes, which is, let's see, I think it's a G, is it a 2083? Let's look real quick. I know most of these codes by, that is, oh, that's a Spravato code, which is great. So Spravato codes are pretty insane. So this is a 56 milligram Spravato visit, $1,311, right? That's for 2 hours. I think the other Spravato code is like 1,500. Let's see here if I can find that. Maybe it's, let's see. Let's see. 2076. And these are office based, so you can use these. You don't got to be like Medicare certified or anything like that. That's an intake exam. I don't quite remember because I do most of mine outpatient now. Just dealing with Carleon. All right. So let's go back, find out where are all these tabs at. I got too many dang tabs open. This is how I live my life here. But most of your fee schedules, again, can be found online. I mean, they're, especially for like Medicaid, Medicare, I mean, that stuff is public information, right? So you can see what you're supposed to get paid. And then they have those new telehealth codes now. Well, that's TMS, right? So these are office-based TMS codes for Medicaid, right? Not too bad either. Let's look at an eval. An eval is 186, and that's right. So you can look up most of the fee schedules and know what to bill. But again, you want to make sure your note has everything in it. And a lot of people ask me, well, the psychotherapy portion's got to be 30 minutes, or it's got to be 30 minutes. That's not true. Does anyone disagree with that? In the chat, write down, let me know if you disagree with that. And then let's go to the literature. Because I think that's important, because a lot of people, even on TikTok, when I was posting on somebody's page, they had me as a guest, how much I make. They were basically in a big argument with me about how much time you have to spend on psychotherapy and what's required. And, the requirement is 16 minutes. And if we talk about the medical complexity portion of it, it don't matter if it takes you 12 hours to determine the MDM portion of it. It doesn't matter, because it's not driven by time, right? If you're just using time, non-face-to-face time counts now. If you're just using time. So effective January 1st, right? Time includes activities such as preparing to see the patient, obtaining a history, performing the exam, providing counseling, and documenting in the health record, right? Documenting it. So if you're just doing a time-based code, if you're not doing medical complexity, which I don't know why you would ever not, that's the easiest way. But even if you put 30 minutes was spent on the date of the encounter, which included activities, and you just put documenting in the EHR, blah, 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 blah. Yeah, see, 99212, you should never code a 99212. You're actually down coding, right? So down coding is just as illegal, but I've never had an insurance company send something back to me and say they didn't pay me enough. I've never had that. I've had them send me stuff back saying that they've overpaid me on claims, which I've appealed and won. But you're never going to see an insurance payer say, hey, you know what? We noticed you downcoded and, we owe you some money. You ain't ever going to see that shit happen. I promise you. That's never going to happen. But yeah, let's go back to the guidelines here. Let's see. Let's share this tab. Right. So when we look at, I think I liked this view better here. There we go. So when we have a patient with ADHD, right, and we're medicating them and we do a dosage adjustment, right, they're automatically going to hit that moderate complexity, especially if you're doing medication management as well, prescription drug management. Where is all this info? I mean, there's lots of places you can get this from. We have that reference right there. And then I like to use Optum because they're the strictest, right? So I just look at what the payer requires. That's how I do it. So that's the best way to do it. You want to look what the payer requires and then build your note like that. As long as you meet complexity, that's right. Let's see. Oh, what am I sharing? Oh, this. Okay. Does anybody have any questions about anything? Anything at all? I don't care what it is. Let me switch tabs real quick here, just so, and then I'll answer your questions here. Let's pull this open real quick. All right, so let's see here. Let's go to some questions here. Just want to get this, so it's kind of in the, I hate the screen share on this. You can never really share what you want. All right. If you do a follow-up 2 weeks after, just to make sure the med is working, yeah, 99214 for sure. I do that with a lot of patients that I'm first starting on a medication. There's labs You can create your own template. I mean, like I said, I just use a blank box, right? For medical history, you don't have to have, some kind of medical history template. You can upload files. So if they have medical history to upload, you can upload them. If you didn't adjust a med, okay, if you're talking about the efficacy of a medication, is that prescription drug management? If you're asking about side effects, are we managing medications during that visit? Yeah, I usually have Simple Practice and my note taker open at the same time. Even with the Simple Practice note taker, which is pretty good, I take that transcript and then I paste it into my Note Genie. So I'll take that transcript that it gives you from the note taker on Simple Practice and I paste it into my note taker and then I run it through, because the note taker on Simple Practice, they don't know clinical practice like we do, and they don't know billing like we do. So it still doesn't meet the elements. A lot of times I'll run a note through there and it's still missing things that are important. Like if my note got audited out of there, they would take money back. I'm 1,000,000% sure. And I don't want that. Denial success. What are you getting denials on? I have a lot of success on denials, especially inpatient. Inpatient denials, I almost never have denials. I can almost usually argue anything, because again, you use AI, and what you do is you just find a list of the questions they ask you, insurance reviewers, and they all have the same questions, right? Dimension 1, dimension 2, do they meet this dimension? And what you do is you take that client's chart information, you paste it in there, and then you ask AI to give you any rebuttals a reviewer may have. So, and then it'll give you the questions that a reviewer would ask, or kind of, question, and then it'll give you an answer for them. Outpatient dual eligibility. Okay, for insurance, so you have to make sure they do what's called a coordination of benefits. So usually it's not always, a lot of times you don't always have to change anything, but you have to change what you're billing first. So if somebody has, let's just say they have Aetna and a Cigna plan, right? Let's say it's a kid and the parents are married. What you would do is you get a denial and it would say patient is covered by other plan. What you do is you take that person's plan, and then in Simple Practice, you can add in a secondary insurance. And what you do is you'd add in the secondary and then switch them. One's primary, one's secondary, and then your claim should go through. And then after you get paid on your primary, Simple Practice actually has a button and it'll say create secondary claim, and it'll create your secondary claim, and you'll get paid on that too. So I get paid on all my secondary claims as well. So I like how it can do that too. Once you get paid on your first claim, you can create a second claim. Yeah. So remember, even if you're not adjusting a med, you're still providing prescription drug management, right? So the AI tool that I used, I coded it myself, because basically I just used OpenAI to train models, because I'm kind of a tech nerd. And I trained the models on all the insurance payers' requirements. So that's how I did it. And you can get a free trial. It's no risk. You can just try it out. You don't have to put your credit card or anything in there. And you can, throw in a little conversation. It can be like 10 words, paste in 2 diagnoses, paste in a med, and it'll create you a note. If you have more than one provider, how do you handle following up on everyone's claims without a billing department? Yeah, so for me, at the clinic I own, I have, I think, 8 providers that work for me there, and I have a billing company that works there, but I oversee everything. But for myself, it's really, if you have 2 or 3 providers, it's really easy to do. And I could probably follow up on all of those providers too. You don't get a lot of denials. As long as everyone's contracted correctly, linked to the tax ID, you shouldn't get any denial. I mean, it's getting denials for outpatient visits is very rare. It almost never happens, right? And another trick here is if patients have high deductibles, which a lot of them do, and at the beginning of the year, you hear a lot of, people can, they complain because deductibles are high. If you prescribe a medication like Vraylar, if you prescribe a medication like Jornay or Azteris or Lybalvi, Caplyta, right? You know how they give you like the little copay cards for the patients? What a lot of people don't know and what they don't tell you is that money that was supposed to be spent to go to the drug actually goes to the patient's deductible. So if I have a patient and they see me in January and I think that cariprazine may be a better medication for them, or something new came out that may target their symptoms better, then what we can do is we can use that copay card and we can eliminate their entire deductible the first visit of the year. So I try to knock out deductibles right away, and you can do that by using a copay card. Yeah, G codes. So we have G2086 and G2087. Those are going to be Aetna and BCBS only, right? So you can only bill Aetna and Blue Cross for those codes. They're the only ones that cover those codes on an outpatient basis, right? And again, we looked at the pay on those codes and they are very, very high, right? I mean, those are very high paying codes. Let's see if I can. I think it was like $500, right? Something like that. Mm-hmm. So, right, this is a recent raise from Aetna. See, I'm over 100% of the fee schedule. I'm at 102% of the fee schedule now. And here's my rates right here. Well, these aren't, I wouldn't say they're my rates. These are Aetna's normal rates, right? It's their behavioral health fee schedule here. So these are their rates. Let's see if I can zoom out just a tad. Let's go down to these G codes here. So here's our G codes, right? And I believe this one is your Vivitrol. If you give a Vivitrol injection, that's what you get for Vivitrol there. So this is going to be opioid use month 1. So if you're prescribing Suboxone, that's month 1. And then you have your subsequent months. And remember, so these can be used in addition to a 99214, right? So what you do is you'd have your diagnoses pointer, it says like A, B, C, D. You'd have your diagnoses pointer 1, and then in the box, it would say F1120 for opioid use disorder. And then what you do is you'd have your diagnoses 2, let's just say major depressive disorder. You'd have that linked to your 99214. So you could actually bill both. So you can set up a claim that looks like this, and I've done it many times. You could have a G2086, now let's do a G2087, and a 99214. So you could have a claim, you can have that in there, right? So that would be 371, and let's just say $100. So that's $500. Nope, you can't add on the therapy code because a G2087. So a G2087 is considered opioid first month visit with counseling. So you can't have a counseling and a counseling code on, even if they're separate and identifiable. You don't have to use a modifier for same day on that one, which is super cool. So you can use that G code. Remember, it's only Aetna and it's only Blue Cross Blue Shield. Same thing for Vivitrol too. Give a Vivitrol injection, $1,400, right? Let's see. Yeah, psychology is a whole different, I'm sure it's Do I offer group rates for multiple providers? No, because it's so cheap already. So for my AI tool, I use OpenAI. I use 4.1, which is super expensive API. Most of these other places, I don't know, Freed and all these other things, there's no way that they're using expensive API. And I could tell, like Simple Practice, they're using their API is booty. It's probably like OpenAI 3.5 or something like that, because it looks like shit, honestly. But API calls, so that's sending it to the AI and getting it back, it gets really expensive. So using 4.1, it's really expensive. It's like almost, I can actually lose money if it doesn't go right. So it's a little bit of a risk because the API calls are expensive. Yeah, see, I've tried that one out. So the API calls I use on my Note Genie, I use 4.1, and it's expensive. So if somebody did more than 400 notes a month, which is totally possible, I would lose money on it. So like, I pray to God nobody does more than 400 notes a month. It's $29.99, and I should have charged $100, but whatever. It's too late now. So it all depends what AI system you use for your notes. It's really important that you know what API they're using. So some use like Gemini, some use Grok, some use Claude, right? There's all those different those AI systems. And then in each AI system, there's different levels of API calls. So that's how detailed it'll make your note, or how specific your API requests are. And some of them are very expensive. Like OpenAI, there's literally API requests that cost like $4 each time you send it in, and they give you very comprehensive answers. And then there's cheaper ones, and then you get into like more of the enterprise ones where you're letting hundreds of people make API calls, and then you start using really crappy ones, right? Exactly. Try mine out for 5 days and see if you like it. And if you don't like it, don't use it. Yeah, writing your own notes, don't do that. How about you take your note that you started, and here, let's do one together real quick. Let's see what it looks like. Let me see if I can make it look a little better though. I'm like really not. There's like no good way to share your screen here. But let's go up here, and let's pretend I'm doing. Let's clear this out. And look, you can even, it works on your phone too, and you can save it to a text file. So if you click that save button, you can't see on my screen, but it will save it to a text file. And then you can also dictate as well. So you see how we're talking right now, you can do dictation. If the patient's in there with you, you can dictate what's going on, and it'll put it in the box for you, which is nice. Stop, right? So you can dictate it, right? Patient reports depression at a 3 out of 10, but let's just mess around with it real quick. Let's say the client has, let's do an F41.1, which is anxiety. Let's do an F33.2. Let's say their depression, let's say it's 3 out of 10. Let's say anxiety. I know I'm not trying to spell. I'm not trying to win a spelling contest here. I'm just hauling. Let's say sleep is poor. Appetite is good. Let's say we increased Wellbutrin from 150 to 300 milligrams. And let's say talked about coping with changing schools. And then this is a 21-year-old male in college. Let's see what it spits us out there. I'm curious. Let's see. Let's see what this does. Let's make it do a note with therapy. All right. I just hit generate. Let's see what happens. And I didn't give it very much there. So that's all I put in there. That's literally it. Right? So let's see. Right? And it even gets the meta right. Watch, if you look down here, Wellbutrin adjusted from 150, right? It got all that. Even gives us psychotherapy, gives us our MDM, gives us our treatment plan, everything. It gives you absolutely everything you need for the note, and then you just copy it. Really easy, right? So here's our evaluation and management, right? Just all I did was put in that. That is literally it. Just this. This is all I put in. And it gave me this, right? Now you know why my API calls are so expensive. So this is a 21-year-old male, right? College student that presents for a psych follow-up, including psychotherapy, challenges with adjusting, changing schools. Did I put that up there? Right? Changing schools, right? Got my depression levels. My sleep has been poor. Mental status exam, review of systems. It's the same, right? We have our plan, medication management. We have why it meets that element of medical complexity. We have our psychotherapy, 16 minutes. That's the time, right? We have to put the time spent, and we have our treatment plan. Yeah, it covers medical. Every note covers medical necessity, right? And then I give people some prompts here so they can know, like, what should I ask if if I have a patient with me, should I ask them some questions, and it'll help guide your note. So if I'm dictating and I need to ask something, has your appetite changed? Any changes in weight? Any changes in your sleep quality, sleep duration, current anxiety level, right? And you can copy this all in here, and it can record it all too, which is cool. And then if you want to save it and come back to it later, there's a save button here, and all it does is it saves it to a text file. That's it. So it'll save it to a text file, and then you can go back to it later and paste it in your chart, or you can just paste it right here, copy it and paste it right into your chart. That's fine. Sometimes I want to go back to it because I want to add stuff, so I'll just hit save and I'll save to a text file. Sometimes I want to copy it. It just depends. So, yeah. And then if I want to change that, you know what? I don't want to do therapy with my note. I just want to follow up without therapy. We can do the same thing, right? We're going to do a follow-up without therapy. And then I just hit generate. And we're going to generate a note. And then a lot of places now, they want like ASAM assessments and stuff like that. And I have that in there too. So we can generate an ASAM assessment. We can generate, see, here we go. Right? I am just here for a med adjustment. And we got all that information from here. All that information turns into this. And it gives my MDM summary here. Office or other outpatient visit for the evaluation of an established patient requires tells it why. The moderate complexity is supported by the presence of 2 chronic psychiatric diagnoses, recent medication adjustments with monitoring, and ongoing management of residual symptoms. Time spent counseling and coordinating care contributed to meeting the 30-minute threshold. So, which doesn't matter if it's 30 minutes or not. Yeah, it keeps it general, so it doesn't list patient details. But I have a BAA with OpenAI, which are very hard to get. Hold on, I'll show you, just so you can see. These are really hard to get too. Let's see here. I'll show you. Share this tab. So I have a BAA with OpenAI. So PHI can go in there technically if it slips in there, but all my endpoints they're 0 data retention, so nothing gets saved, which I like. Some people are like, oh well, this app saves the list of my patients and the list. Like, I don't want all that. Like, I'll just click load previous note from the last visit, paste in my diagnoses, hit my med changes, and hit submit, and the data's gone. I don't want it saved anywhere. Right? So let's see. So I already have my So I already have one of these. It's my HIPAA compliant. Yeah, you don't need to save anything outside the chart. So there's no name. So you can basically just go in there. Like what I do is I go into my patient's chart, I copy the med list and diagnoses, boom, and that's why I keep them close to each other on the note, and then I paste it in my template, in this note template here, right? I just paste it in there and then put like 3 or 4 words or dictate and then generate. So it's really quick. And say we wanted to, say if you're a therapist and you wanted to do a DAP note, or you wanted to do a DAP note. See, I have a DAP note and it tells you what to ask for. I have an eval, I have TMS mapping, I have Spravatos, I even have your G code in there, right? A G code really wouldn't apply to this, but you know, let's see what a G code would. Biopsychosocial, discharge summary, which is great if you work in a hospital. So discharge summary, see, and I give you the prompts here. So sometimes you can just copy the prompts, you take the prompts, you paste them in there, right? And this is easy. Discharge diagnoses, you put like F33 2, F41 1, reason for admission, MDD, treatment provided, daily, group, therapy, med management, counseling for 30 days, fair, still has work to do, follow up with psych and therapist, well, Utrin, milligrams XL. Let's do a guarded prognosis. Can't spell prognosis. Let's see what it spits me out here. So usually I'll just go into the chart, I'll copy some of the eval, I'll just copy the HPI from the eval, history of presenting illness, copy the diagnoses, copy the med list, boom, and then just generate. And then I have a discharge summary. So administration can quit hounding you for discharge summaries, right? It takes 2 minutes. See, here's our discharge summary, right? And my API barely makes up anything. It will sometimes if it knows you need it for the note, it'll make it up. And then you just got to go in there and modify it. But let's see here, right? And it's pretty accurate. So we talked about 30-day treatment care, MDD, right? Reason for admission, 30-day program, Wellbutrin, follow-up, right? All that stuff. Right? That's an entire discharge summary from this. And all I did was, and some people even will copy that down there, they'll paste it in, and then they'll hit the dictate button, major depressive disorder. You know, daily CBT therapy, right? They just dictate it all in there and it'll lump it all together. It's an app / I mean, it's not really an app. It's not on the App Store, but it's on a website, and you can try it for free and see if you like it. You don't have to put in your credit card or anything. Try it out though. Right. And we also have, you have your therapy dApps, therapy soaps, right? There's a soap note. And it'll generate a note just about based on almost anything. That's a psychotherapy portion, right? 29 bucks a month. Holy, 90 minutes for an eval 99204 and a 90836. So first of all, if you use, okay, let's go through this. So Nej brings up a great scenario. Let's go through this scenario here. So he's doing a 90-minute new eval. He's billing for a 99204 and a 90836. So if we're doing a 99204 and a 90836, the first code has got to be driven by complexity, right? Because you can only have one code that's driven by time. So automatically we know that that should be a 90838 already, right? Because a 90836 is how many minutes? Let's go to our Optum. Where's our doc here? Let's go back to that. So does anybody know how many minutes a 90836 is? I know one of you guys knows. So a 90836 is 45 minutes, right? So 45 minutes. Was it longer than exact? Well, it's 38 to 52, right? So 38 to 52 minutes. Your visit was 90 minutes, right? So automatically you're already at a 90838, right? So the 99204, based on complexity, it could be a 99205. I don't know your patient, but that's automatically going to hit a 90838 just by time, right? And if you're billing it, well, you can't. You can't bill it based on time for the 99204 portion, because if you use a time-based code, you can't use another time-based code. You can only have one time-based code. So you can only have a time-based and a complexity code. You can't have a time code and a time code. You can't do a 30-minute visit to hit your 99214 and then 30 minutes of psychotherapy or 16 minutes of psychotherapy. So 46 minutes, like, it doesn't matter, because that first part of the code doesn't have anything to do with time. It can take you 12 hours to figure out that portion. So. Any other questions? So we should know that 99214, super easy to hit, right? Just make sure in your chart you have the 2 diagnoses and you have the medication management. That's easy. That's a 99214. For your psychotherapy, make sure it's documented correctly, all right? Make sure that the description of the type of psychotherapy content is provided, and total time spent, as well as the progress and response. 500K is easy. You can do that easy. If I'm averaging, and I've shown you guys my reimbursements already, so it's not a secret. You even saw the Medicare reimbursements. I do 20-minute visits. If I do 3 20-minute visits at a time, that means I'm making $600 an hour, right? Usually I'll do about 10 hours. I'll do 8 hours. It just depends on whatever I want to do. But if I do 10 hours at $600 an hour, right, I'm making $6,000 a day, right? That's $30,000 a week. I got some really good marketing tips, but I'm not going to give them away because they're really badass. Actually, one of the ones I shared in my community, I was just messing around and showing them about changing a zip and targeted, and I got like 4 calls from new patients. I turned them down. I'm not really taking any more patients right now, but how do you get new patients for that much? It's not. I'm just billing the CPTs. Oh, how do I get new visits like that? The new visits, I mean, for me, new visits actually pay less than follow-ups because you can do so many of them. But yeah, I mean, you can do $600 an hour. Let's see if I can. I'll share something with you without sharing PHI. I'll just give you an example, because I really only see patients like Mondays and Fridays for private practice now. I round. That's where I make most of my money rounding. So I get, I do about 800,000 a year rounding. But we'll see here. I'll just show you. So we'll just look at, let's see. Just want to make sure. So this is me just basically working Mondays and Fridays. That's it. So Mondays and Fridays, that's it. These scattered ones I threw in there, that's because like a patient hit me up and needed something, and then like I did a quick visit with them or whatever. But for the most part, and all my money from June hasn't hit. Usually I get a big deposit on Fridays. So like look at last month, just working Mondays and Fridays. Just working Mondays and Fridays. Let me move this over so you guys can see here. So let's see here. So that's this month so far. Oh, I won't show it. You back out. How do I get rid of my logo? Hold on. Let's see here. Design. Let me get rid of my logo here. There we go. Okay. So that's last month, just Mondays and Fridays. That's it. Mondays and Fridays. Mondays and Fridays. That's it. $22,000. Easy Mondays and Fridays. Look how packed my schedule looks though on Mondays and Fridays. That's fine though. And that's, about my average. So just Mondays and Fridays. And then I round too. So you can make that much working 2 days. No, I'm just doing basic psych visits. That's it. Just 99214, 90833s. That's what all these are. Very few cancellations, right? Because I always call my patients. I send them a reminder, like right before the appointment, you can click here and then send a reminder, send them a text reminder. If they don't answer, I call them. Hey, man, how's it going? Your appointment's supposed to be right now. We could do it by phone, right? So I'll do it by phone. I don't, let me see if I can. Let's see. I want to see if I can. I don't want to click on it. I don't want to reveal any PHI, but I'll see if I can show you my insurance stuff. Just kind of, I'll just give you like a little snidbit here. So let's share this tab. So you can see like, here's all my insurance payments coming in, right? I very rarely have zero pays, almost never. But you see, this is all going into my bank account. Then I click on it. I can see the EOB on it. I'm not going to click it because it'll have the patient's name, right? But I have Aetna, Cigna, Blue Cross, Medicaid, right? And then, yeah, so. No, you don't have to link the EOBs to the patients. They're automatically linked. They do not have to be linked. They automatically link. Like if I click one of those view payments, the EOB comes up. And you can see the EOB in Simple Practice. Here, let me see if I can show you without sharing PHI again. Let's see. We'll go to billing. You're not seeing that tab. Good. Let's go to insurance. Let's go to my payments. Let's just click a payment here. Let's see if I can show you what it looks like here. So. I got the EOB in front of me. I just can't tell you. I can't share it because it has the patient's name. How does it transfer the payment to reflect on patient's chart? It just goes in there automatically. It's, you don't got to do anything. I use Loom. Like if you, I use Loom to like teach my students like how to do it, and I can blur things out, but I can't share an EOB on here with you because it'll have PHI. Then you get my requests. I have my eScribe right here, which is nice, right? So you have your appointment requests. And then like I use my website. So if I have my website, let's go to my website, next step, recoveryaz.com. No, I don't want to log into it. I just want to go to my website. So let's go to my site. And then patients call me on Psychology Today. What I tell them to do is go ahead and log into my site, hit that request appointment button, right? And then they can request it. It goes right to my simple practice. And then it goes to that appointment request, approve what documents I want. And then I see the patient. They throw in the insurance information. So, right, telehealth. And then it shows, see how it's only Mondays and Fridays? And they book right there from my site. And it's right on my Psychology Today too. So I give the, let me go and log in. Whatever logs in there. So this is my Psychology Today here, right? Endorsements are big too. Endorse each other. Everyone go on there and endorse me. I'll endorse you back. That helps the algorithm. It really helps your algorithm a lot, right? And I have 2 Psychology Todays. You can only have 2 for each state, which sucks. So I have one for Arizona and Vermont, and then I have another one for Colorado, New Mexico. So this is just Arizona, Vermont. So look at this here. I have almost 900 web visits, 423 calls, 300 emails, 1578 contacts. Video plays are good. I've been viewed 100,000 times. But let's look at my profile. So what I have in here is, see, I have my link book now on, and then most of the time people are like, oh, I can go to his website. But look, you can't put .com, it'll blank it out. So what I do is I put a space in between the .com there, so it allows it. Right? And then endorsements are important. What insurances you take, right? You can look at all your endorsements on there. So it's good to endorse people, get endorsed back. It really helps out the algorithm. Do I use an appointment pre-screen? Yeah, I do. I just use the one that Simple Practice gives me. And I don't really, I mean, exclusionary, I really wouldn't say anything's exclusionary. 99214 and a 90833. What was I just on? I don't remember what site I was on. That's how bad my memory is. Oh, that was Psychology Today. Yeah, so Simple Practice works really good for multiple providers. So hold on, let me show you here, I'll show you the practice that I own too. So this is on top of, this is just passive income, this other practice that I own. It's very, I have a 10,000 square foot clinic in Phoenix. So when I'm not, let's see here, let me do privacy here. So here's the practice that I own. I'll show you. So here's the practice that I own. Right, here's all my providers. You do about 80,000 a month, all telehealth there, right? So what I do is I pay my providers $150 an hour. So I'm paying them $50 per visit essentially, because they do 3 an hour. So they're making $150 an hour, which is really good, right? Not a lot of places pay $150 an hour. So I'm paying $150 an hour, but what am I generating on that, right? I'm generating $500 an hour, right? I'm generating $500 an hour. Let's just say $500 an hour. And I'm paying the provider $150 an hour. So I'm generating $350 an hour per provider per hour. That's what I'm making, right? But I'm still paying them $150 an hour. Right? So I'm making 2 times, and this is how clinics make so much money. Like, people don't understand that, you know, like they're making a lot of money. Now I try to pay pretty well, but still, right? If I get to keep 80%, why would they do that? Dude, good question. That's exactly why I didn't do that. And people have mentioned this before. Once you see the reimbursements, it's like someone said, it's looking into the matrix, right? You can't go back, right? Once you know what the reimbursements are, it sucks because you're like, I'm getting fucked, man. Or, you know, I can't say I'm getting screwed, right? Does this practice have their own biller or billing department? Yeah, I got one guy and I pay him $2,500 a month because the claims auto generate. All you do is click send. There's like 0 claim follow up. Do I credential everybody? Yeah, it takes me 45 minutes to credential somebody. And I got group contracts. Credentialing, people make it sound like it's real difficult. It's not. You just got to fill out forms. I know everyone loves that. You know, well, why do people take that low much money if they know you're making that much? I don't know, man. Supply and demand, dude. If you're willing to work for that, then, you know, nobody is forced to. And I let them do their own schedules. So I let them kind of, you know, they can pick out their own schedules. They can work when they want. See, here's that's the 23rd. That's a pretty busy day for my crew there, right? It's a busy day, right? So these are all. If they leave you, they can open their own. Great. I would love that. I'm not trying to hold anyone back. I would help them. Every single one of my providers, not only do I add them on as a provider on my group contract, and you can ask my providers this, I think one of them is on here. I help them get their own contracts in case they want to leave and do their own thing. Every single provider that I have, I help them obtain their own contracts too, as a courtesy. So not only do I get them on my group contract, I help them get their own contract. So every single one of my providers, I get them contracted so they can do if they want to do their own thing, they can. The only rule I have is you cannot take patients that I got with my marketing, right? So if you want to have your own private practice on the side, go ahead. I don't care. Do it. I'm not going to make you sign like a no compete split or on hourly rate. No, they're paid per visit. $50 per visit. I can show you here. I'll show you what one of my contracts looks like. Here, APRN, contract agreement. Here, I'll pull one up so you can see what it looks like. So let's see here. Can I share this tab instead? I probably can. Let's go to share, replace screen share. So this is what a contract looks like from me, right? So I had somebody sign that. Let's see. So they get paid $50 for a visit, or they get paid $150 for an eval. I don't know what happened. It stopped letting me share my screen. I think I maybe went over the time limit. Yeah, so that's Note Genie AI that I use.